Welcome viewers to our podcast series Medilumina, proudly hosted by Dr. Lal Path Labs. Dr. Lal Path Labs, a name synonymous with diagnostic excellence, a pioneer that has consistently brought cutting-edge technologies to the Indian medical landscape with the most expanding and advanced diagnostic networks in the country and a track record of being first in India to introduce several high-end testing capabilities. In this series, we journey into the forefront of healthcare diagnostic innovation, bringing you the stories, insights, and breakthroughs that are shaping the future of healthcare in India and beyond.
We have our state-of-art Center for Excellence under LACE to diagnose various systemic autoimmune diseases. We all know and we need to be aware of the fact that the incidence of autoimmune diseases is on the rise in Indian scenario as well as globally. And the incidence has risen post-COVID-19 and some of the data reflecting is as high as 30% rise.
In this podcast series, Unraveling the Mysteries of Autoimmunity, myself, Dr. Ajay Gupta, Technical Director, Department of Rheumatology and Immunopathology at National Reference Lab, Dr. Lal Path Lab, along with Dr. B.T. Pandey, Head of the Department of Rheumatology at Fortis Scots Hospital, will be discussing a complex and often misunderstood group of conditions, a solution-based strategy, myositis. Myositis, a group of rare muscle diseases characterized by chronic muscle inflammation and weakness. It occurs when the body's immune system mistakenly attacks the healthy muscle tissue, leading to the muscle fiber damage.
We welcome Dr. Pandey. To begin with, sir, do you agree that the incidence of autoimmune diseases have increased post-COVID-19?
Thank you for inviting me to this interesting podcast, and I'm delighted. And this is a very pertinent question that you have asked about the disease prevalence which has come up post-COVID. We do not know why, but we definitely see a good 10 to 15% increase in total number of references that we see on a day-to-day basis. We have a lot of hypotheses. As on today, we do not know the hypotheses in a detailed manner. Worldwide, there are people who are looking into these specific inputs of increased autoimmunity per se in varied conditions. So it may be just lung hyperresponsiveness or more autoimmune type of skin diseases, which are too many, or autoimmune rheumatological diseases, say lupus or undifferentiated connective diseases or rheumatoid. That shows that there is some connect between an etiology here, a virus, and body's response. We should not forget, we learned a lot from Epstein-Barr virus models that we can induce autoimmunity, and we know lymphomas, lupus, they all go haywire due to this Epstein-Barr. So it's nothing new, but yet our body's response to a very novel type of virus is very well being captured worldwide, and we are getting better informed over a period of time. So it's a question still unanswered because it will take time for science to understand it.
Absolutely correct. Yeah. So viewers, today we shall be discussing with Dr. Pandey on a very important topic rather than a disease segment, which is idiopathic inflammatory myositis, and this will be our volume 1. So to begin with, Dr. Pandey, we all know that idiopathic inflammatory myositis is an umbrella term used to classify various types of myositis. What are the various clinical features observed in a suspected case, and how can we differentiate various subtypes of myositis based on the presenting clinical features?
Fantastic question. So myositis, as we knew before, was basically when the skin was involved with a muscle involvement called as dermatomyositis, when there was not a skin involvement but lot of muscle involvement called polymyositis. Then we had the cancer-associated myositis, the juvenile forms, and an inclusion body. This was a broad term that we knew. Now we do not want to be categorized in these 4 or 5 domains, or necrotizing myositis also, which I would like to mention. Now we would like to know this umbrella term in a very novel manner. And this has helped us because if we try to put myositis, we would like to see the different clinical context or construct in which the patients of myositis present, and there is some differences in them. So if a person comes with a lot of skin involvement, which can be heliotrope rash, it can be Gottron's papules, we all know about various mechanic hand and other skin phenomena, and muscle weakness, which was erstwhile called as dermatomyositis. But as on today, when we do the antibody characterization, we now know it is something different. And because of that, now we can broadly classify in a different manner. Now we can say myositis like anti-synthetase syndrome, where there's a good amount of skin involvement, not very profound muscle involvement, but lung involvement is quite high. This is the commonest form of myositis that we would be encountering. The erstwhile dermatomyositis would be a typical antibody MI2 driven, where there's a lot of skin involvement, muscle involvement. But then you can have the other various forms like antibodies to MDA5, where there's a lot of skin involvement, fulminant lung involvement, but not much of muscle involvement, which is a myopathic form. Then you have the erstwhile described pediatric forms with NXP2 TIF gamma. In the adulthood, NXP2 and the TIF gamma is associated with cancers. So we are getting away and trying to understand the specific antibodies which are specific for specific type of inflammatory myositis, and what do they do to the body. Why we would like to know is the outcomes are different, the presentations are different, the treatment options and goals are different, and moreover, they may be associated with cancers. So whom to screen for what should be our approach has all changed, because now we have a word called myositis specific antibodies. So there are antigens for which a body makes an antibody, and through that we get a lot of information how body's response to different antigen is different. However, this is again unanswered question, because 40% of the patients do not have any antibodies. So we are still 60% sure of our people with the disease.
Right, that's very interesting. So you mentioned about anti-synthetase syndrome. So how do we diagnose anti-synthetase syndrome, and do we need to have a separate myositis antibody profiling to diagnose the same?
Very interesting, because anti-synthetase syndrome, most of the time they come with a lung involvement, and they do not land with a rheumatologist, they land up with pulmonologist. So it's a multidisciplinary approach, because they come with a lung involvement. They are ILDs, and these ILDs have a good amount of skin involvement, not much of a muscle involvement. Now, they will hardly, and sometimes they may have the joint association, they may have Raynaud's phenomenon, but that does not bother the patient. So they are seen by a different group of physicians, here the pulmonologist. Now this is the area where people, both pulmonologists, rheumatologists, the dermatologists sit together to understand what disease, anti-synthetase. What is that unique phenomena is some of these patients may land up with the pulmonologist in the ICU, and they are not recovering because the lungs are not getting better, and they require immunosuppression and on antibiotics. And this is how we learn from each other, where a call is given from the ICU, from the pulmonologist or the critical care expert, that the patient we are unable to wean them off. Some of them progress in, say, weeks, subacute to chronic, but maybe before some time. So this anti-synthetase syndrome should be always investigated in a patient who has ILD, where you could not establish CTD associated ILD. So that means you have done a workup for connective tissue disease based on the clinical construct that you had, and if that is not positive, AN is not positive, the specific antibodies which are there in anti-synthetase is specific for disease. The associated antibodies, say PMSCL, ANA strongly positive with COO, antibodies, they are the associations. Now those are there in CTD-ILD. So ILD per se should be investigated further for CTD-ILD or myositis associated ILDs. So this is how broadly, unless we know what is happening to this immune system in the lung. Why is the lung getting affected? So it's a broad term, antisynthetase. Many types of antibodies are there. The commonest would be anti-Jo, which is very, very important, and they are very specific. The very important part is that the moment we say myositis, we say specific antibody. That means we do not get 2 or 3 or 4 antibodies. You get one antibody, which is usually the principal antibody. A bit 1 or 2 other antibodies in weak titers are supposed to be not taken care of, but the strongly positive specific antibody should be taken. Here specifically, anti-Jo is the commonest. The largest population would be anti-Jo, Jo1 positive.
Right. Now, anti-HMG-CR myositis. Now, it's rather not very common, but it is associated with prolonged exposure to statins, and even patients who have no history of statin intake. Now, what do you think is the role of testing anti-HMG-CR antibody in suspected cases, and do they have a role in the prognosis also?
This is very, very difficult construct, the HMG co-reductase. So this is an enzyme in our body, we all know, but if our body starts making antibody against this, that's what we call. And it has nothing to do with the statins. At least to the majority of population which gets this form of necrotizing myositis, it is not the statins. You may, at 30, 35, you may get this disease, which is a fulminant sort of a course where you get a lot of muscle involvement. Your muscle enzymes are in 10,000s, and within no time your muscles are being replaced by fat. So unless you do a antibody understanding or a biopsy to show that these are necrotizing, you can't diagnose it. But the clinical context is very simple. Statin associated or statin induced is not the correct word here, because statins do cause a myopathy, but not myositis in majority of patients, and that where the CPKs are in a few hundred elevated. Here there are specific antibodies which may be formed de novo and just not because of a statin. Statin is what? A substance which prevents the HMG co-reductase. So there is a blocking agent. So these are not the perfect antibodies against which the antigen against which the body makes it. There is a subset for which the body makes an antibody. So statin may be implicated or may not be implicated. But once you have this, it is very important to act fast, because you lose muscle within no time. And even if the person survives, he survives without muscle. So do we expect a young person to get out of the bed all the time despite the disease well controlled, because he is left with no muscle mass? Act fast. So this test is very important when you are suspecting very high CPK. And if you have this test, you have an advantage, because someone may say, I do not want a muscle biopsy. But if you have very high CPK and you have and I said specific antibodies, so if you have a HMG co-reductase antibody strongly positive, what do? You act fast, you give the best drugs possible, because they may require high dose steroid, they may require endoxan, they may require rituximab, plasmapheresis, everything on earth they would require for the disease to be well controlled. So they were very, very important in select patient population.
In fact, sir, we at Dr. Lal Path Lab, we were the pioneers to launch this test last year. And not only HMG-CR myositis, but the extended panel of 16 antigens with myositis specific and associated antibodies also. So, viewers, today this was episode 1 for idiopathic inflammatory myopathies, and we thank Dr. Pandey, and we shall be continuing this series in episode 2. Thank you, sir.
Thank you to all our listeners. I look forward to your views, your comments, and how we can make this podcast better. Thank you.
Thank you.